Hi, my name is Eileen Fowler, and I'm the director of the Cameron Gait and Motion Analysis Laboratory in the Department of Orthopedic Surgery at UCLA. And I'm also on faculty in the Center for Duchenne Muscular Dystrophy at UCLA. And today I'm going to be talking to you about physical therapy and outcome measures for clinical trials in Duchenne muscular dystrophy. And we're going to begin with clinical assessment. So one of the hallmarks of Duchenne muscular dystrophy is proximal weakness. So many muscle diseases have different hallmarks. So proximal weakness is when the shoulders are weaker than the elbows or the wrists. The wrist muscles would be more distal muscles. And also the same thing with the lower extremities. The hips are weaker than the knees and the ankles. So in order to test this, we ask the child to come to standing, and they do it in a typical way that's very unique, and it's called a Gower sign. And this is an example of a child coming to standing. He rolls over and then pushes up with his hands and uses his hands to walk up his legs to come to standing. So today I'm going to be talking to you about phenotypes. So you've learned about genotypes also in this course, but phenotypes are the clinical presentation of the patient. And it can be either that a child has a mild phenotype or a severe phenotype. So today I'm going to be contrasting two different children, one with a severe and one with a mild phenotype. The first child is case study A, a 7-year-old boy. And his clinical symptoms began when he was 5 years old, but he wasn't diagnosed until 6 years, 7 months. And this isn't unusual in Duchenne muscular dystrophy because many pediatricians and parents are not familiar with this disease. His birth history is that he had a full-term normal birth, and his developmental milestones early were quite normal. He walked within 13 months. However, he did have low cognition and developed an intellectual disability. So that was like a red herring that maybe made the pediatrician suspect that he had a developmental disability rather than a muscle disease. He lives at home with his parents. His mother is Spanish speaking and requires an interpreter. And his mother has also had great difficulty with accepting this diagnosis, and she becomes very tearful in clinic, requires a lot of support from the social worker. So it's hard for her to focus in on some of the things that she needs to do. And he also has behavioral concerns. So he doesn't often comply willingly with some of the treatments that he needs to have for his Duchenne muscular dystrophy. So he began falling when he was about 3 years old and had trouble rising from the floor and climbing stairs. And with increasing age, he began to fall more frequently. His genetic background is that he has an exon deletion and he had high CK levels. He was diagnosed and followed at UCLA's multidisciplinary clinic. And he was started on prednisone when he was diagnosed. And prednisone is a type of steroid. And this type of steroid is FDA approved. So insurance will pay for it. And steroids are the standard of care for all boys with Duchenne muscular dystrophy. There's another type of steroid that we'll talk about a little bit later, deflazacort, and that's not FDA approved, but some parents and clinicians feel that there's fewer side effects. So some children are on that, but as this family may not be aware of this other type of steroid and may not have the financial resources to afford it otherwise. So that's just another difference that sometimes we see between families of what type of steroid the child is taking. He also is taking calcium and vitamin D supplements, and this is because bone strength is affected by steroid use negatively, and also bone strength in children who don't jump and run and play. They have less force on their bones, so the bones don't grow to be as strong. And the family also decided on their own to discontinue steroids for this child, and so I'll discuss a little bit more about the implications of that in a subsequent slide. Okay, he's followed by a physical therapist monthly, and originally the diagnosis was developmental delay. And because of that diagnosis, the therapist focused on increasing his activity, his strength, and working on motor skills. And that is not what you would recommend for a child with Duchenne muscular dystrophy. She did, however, suspect that he might have a muscle disease and referred him to a neurologist at 5 years. But for some reason, he was not diagnosed a year later, so she referred him to UCLA for our natural history study of DMD. And in that process, we arranged for him to be seen by our neurologist, and he was given a diagnosis. And after that diagnosis, he's been followed in our clinic, and therapy began by initiating daily stretching program. He was initially provided with a walker for forearm rests at school, and that's also because they thought he had a developmental delay. And so for children that have lower extremity weakness, such as cerebral palsy, you might give them a walker where their stronger arms could help to support the weakness in their legs. But since he has weakness in his arms as well, a walker is not recommended for Duchenne muscular dystrophy. So once he received that diagnosis, the walker was discontinued. So the parents were instructed in a regular stretching program, and night splints are also recommended to maintain ankle position during sleeping. But this child refused night splints, and he had temper tantrums, and if they were put on, he took them off during the night. He eventually developed abnormal foot and ankle postures and a contracture. And because of that, serial casting and Achilles tendon lengthening was recommended. And one of the risks of doing surgery in these children is that it causes them to be off their feet for a period of time, and immobilization causes additional weakness, and the child may not resume ambulation afterwards. So we really do want to focus on maintaining range of motion using conservative methods whenever possible. He has a manual wheelchair, but he's in the late ambulatory stage now of Duchenne muscular dystrophy. And the wheelchair doesn't provide him with independent mobility. So at this stage, we would recommend scooter and a power chair as a better alternative. So I'm going to show you how he walks. And when we look at gait for these children, we want to look at compensations that occur because of weakness. So the body automatically compensates if a muscle is weak. Before we even start the video here, you can see that his calves are a little bit enlarged. And that is another hallmark of Duchenne muscular dystrophy that you can see before a child is even up and standing if they're just sitting in their chair or laying down. So here he is walking, and you can see if we start at the foot and work our way up that he doesn't have a normal heel contact with the floor. He contacts with his toes instead. His knees are on a little bit of excessive extension. You can see that he has an arch in his back, and he has what's called lumbar lordosis. And he also has his whole trunk in extension and his arms and back of him. And all these compensations are because of weak hip musculature. And here's a list of compensations that you can look at. If we look at from the front, we can see this sort of waddling from side to side. And that's because of hip abductor weakness. So the hip abductors on the stance side hold up the pelvis so it doesn't drop on the other side during swing. And you can see that he's moving his trunk from side to side to try and minimize that lever arm, and that results in that kind of waddling gait pattern. He also has a wide base of support, which we often see in children that have poor balance. So now we're going to look at this test of supine to stand, and he is in the late ambulatory stage. So he can no longer do this independently by crawling up from the floor, and he needs to use a chair. So I'm going to show you a little bit of him beginning trying to come to standing. This takes 114 seconds for him, so we're not going to wait for him to rise completely to standing, but eventually he does get up with support of the chair. He is unable to flex his neck against gravity. He's unable to perform hip abduction, and the therapist is showing him here what she wants him to do, and now she's asking him to do it independently. And he can slide his knee forward, but he's unable to use his hip abductors. He rolls a little bit on his back to see if he can get some help from the hip flexors, but he's unable to do this independently. At 7.5 years, he discontinued the prednisone without medical device because the family was concerned that he was gaining weight. And he also had behavioral issues which exacerbated with the prednisone. As a result, he ended up stopping walking, and when he came back to clinic, he had reduced pulmonary function. He had more of a lordosis of his spine and had developed a scoliosis, so he was referred to orthopedics to evaluate that further. He also had developed a contracture at his ankle, so Achilles tendon lengthenings were being considered. And prednisone was re-prescribed, and the family was provided with nutritional counseling. So now we have review questions, and I'd like you to name 2 typical gait abnormalities based on the videos that you just saw. So here's a list of different gait abnormalities. We talked about lumbar lordosis, a backward trunk lean and lateral trunk lean, and also the wide base support and toe walking are some of the common gait deviations that we see in DMD that this child did exhibit. Now we're going to move on to a child with a very mild phenotype. This is case study B, and he's 7.5 years old. So this child was diagnosed earlier at 4 years of age. He has a higher level of function, and it's actually more consistent with Becker phenotype, which is a milder form of a dystrophinopathy. He also had a normal full-term birth, and he walked at 15 months, which is normal. He had a speech delay, which also can be another reason why someone might think that he would have a developmental delay. And he also had a growth hormone deficiency. Now the parents noticed that the symptoms at 3 years of age. He had complaints of pain in his back and his legs, and he was asked to be carried everywhere. So when they went to the pediatrician to discuss this, the pediatrician said that it was probably behavioral and they should really push him to be more active, which is something you wouldn't want to do if a child had a muscle disease. He was referred to a gastrointestinal doctor or GI doctor who suspected that this child might have DMD. The first symptom that he noticed was the enlarged calf muscles. So in addition to the GI workup, he also did a CK level and found that he did in fact have elevated CK, and the child was referred to a neurologist. So this child was prescribed deflazacort at the parents' request. They were very internet savvy and went online and connected with other parents and decided that they wanted to try this type of steroid for their child. They also have the child on growth hormone due to that deficiency and Prevacid for his acid reflux. And he also is on vitamin D and calcium for his bones in addition to some supplements. So the parents perform daily stretching at home with this child. He is compliant with night splints to maintain his ankle range of motion. He has adaptive physical education at school, and he uses the manual wheelchair for long distances. And he's able to walk around school and walk around home without needing to use a wheelchair, but for longer distances like field trips and things like that, he might use a manual chair. For schoolwork, this child does not have a cognitive disability, and in fact, he has advanced performance, and he attends a multidisciplinary muscle disease clinic. So if you saw this child walking down the street, you wouldn't pick up that he had anything wrong with him. You can see that he has initial contact of the foot with the floor with the heel, and he may have a little bit of an exaggerated arm swing, but that also could be behavioral because he had a lot of energy during his evaluation. When we did look at his evaluation, we found that he had early heel rise at the end of weight bearing, but we could only pick that up with a sophisticated gait analysis. If we look from the front, again, we don't see very many abnormalities, just a little bit of sort of lateral pelvic side to side or wiggle in his pelvis if you look very closely, but very mild. You can see, however, that he has very enlarged calves. And here is this child coming to standing. He does not have a Gower sign as he doesn't roll over onto his stomach, but you can see that he pushed up with his right hand. So it shows that he exhibited a little bit of weakness of the right quadriceps. He's able to perform full neck flexion, which is unusual for a child with Duchenne muscular dystrophy. He's able to abduct his hip against gravity. When he gets to the end range of motion, he starts to come forward a little bit, so that does exhibit slight weakness. He's able to go up the stairs step over step, which is normal. Coming down, he does one step at a time. And this is actually a good method of conserving strength for a child with Duchenne muscular dystrophy. He doesn't need to hold on to the railing, and many children do. This child is able to perform advanced motor skills that many children with Duchenne muscular dystrophy cannot. He's able to jump with both feet quite high. He had to touch the floor when he came down, but if he hadn't jumped so high, I think he would have been able to do that without touching the floor. Also, he's able to hop on one foot. So he did 3 without stopping, which is a little bit fewer than a child his age. Here he can do a few more right now, but 10 would be typical, and he has low clearance, so there's slight limitation. So if we compare both of these children, we can see huge differences in their phenotype. We also performed 10-meter walk-run with both of these children, where we asked them to walk or run 10 meters, and then we time that test. So we can see a big contrast, 34 versus 3 seconds for that test. The supine to stand, 114 seconds versus 1.7 seconds, and climbing 4 stairs. Case A, the child was unable, where case B, he could do it in 2 seconds. And so for case B, really all of these times were within normal limits for a child his age, so he didn't show any disability on these tests. We also examined range of motion, and this is a physical therapist stretching the heel cords. And if you're in neutral, that's 0 degrees. We can see on the little slide on the little picture on the right that if you can come above neutral, that's dorsiflexion, and normal range would be 20 degrees. So case B had 5 degrees on the left and 10 degrees on the right. However, case A was in minus degrees, so he was in the plantar flexor range of minus 10 degrees on the left and minus 10 on the right. So that means that he has a contracture. And the plantar flexors are heavily used during toe walking, and that minimizes the work of the hip muscles. But this can lead to contractures because one muscle is developing a lot of strength, and the dorsiflexors on the other side of the joint are weak. So for subject A, he did exhibit toe walking, he didn't wear his night splints, and he did develop contractures, and so now tendon lengthening surgery is being considered for him. So you just saw videos of a clinical examination of 2 different boys with Duchenne muscular dystrophy. After the examinations, the therapist found that the phenotypic representations for these boys were quite different. So I want you to take a moment and compare and contrast and maybe explain why we think we saw some of the differences that we did.